It's my pleasure today to talk to you about stentless ureteroscopy as facilitated by a 6.3 French ureteroscope. These are my disclosures. The rationale for using a smaller ureteroscope to allow stentless ureteroscopy is clear. The need for a postoperative stent is related to trauma to the ureter, and a smaller caliber ureteroscope requires little or no dilation of the ureter, and theoretically there should be less trauma. The newer 6.3 French ureteroscope design has the same working channel and deflection abilities, and so it should allow us to achieve the same surgery we're doing with the larger caliber scope, just with less trauma, therefore less need for a stent. Potential harms, of course, of any new device are failure to achieve the desired outcome and the delayed need to stent in certain situations. So I'm going to present to you a few cases that we did. First one was in the office, and the others in the ambulatory surgery suite that we have using the 6.3 French scope. In all these cases, we were able to do them stentless. All these were performed by myself using a UGMed 6.3 French flexible ureteroscope. A thulium fiber laser was used when performing laser procedure, and 2 French bug bee for the office tumor ablation, as you'll see. And all procedures are done outpatient, totally tubeless basis, as mentioned. So this first patient here is a patient who's had bilateral upper tract urothelial carcinoma that I've resected in the past. In the office, I'll do surveillance ureteroscopy on these patients. So here I went up to the right collecting system, inspected it. You can see that the view, with the digital quality of the view, is excellent. And now we're going down the ureter and observing for any tumors. We observed on the way up. We also observe on the way down. And because we're using a no-touch technique, we can identify carcinoma in situ and even subtle disease very nicely. And you can see that the image quality is excellent. You can see blood vessels. You can see the entire lining. Because we're not using a larger caliber scope, not having to dilate, it's easy. Now we're going to the left side. You can see all we do is just swing our ureteroscope in the bladder over to the left ureteral orifice. And once we identify it, we try to adjust our ureteroscope position to be able to get up the ureter easily. You always want to go through that little flap at the UO. Now we're going up the ureter, and you can see we're not causing any trauma as we're going up, and we're going up under direct vision. So we're slowly making our way up the ureter because the purpose here is to make sure that there's no disease in the ureter. Once we reach the kidney, we explore the kidney. We turn our scope. You can see that one-to-one torqueability of this scope is excellent, making it easier to see all the calyces. We're visualizing calyx by calyx, making sure we map the entire collecting system and make sure we don't miss any lesions. And you can see this whole procedure took just a couple of minutes here. Now we're in the bladder, and there was a tumor that we had noted initially when we got into the bladder. And there's a tumor there that we're ablating with the same ureteroscope. So there's a 2 French bug bee electrode. It's done in the office. You can see you get excellent hemostasis and a thorough ablation. And you can do the entire procedure with the ureteroscope, which is a big advantage. So this is basically what the ureteroscope looks like. And I'm demonstrating here a couple of features. One is there's a toggle on the ureteroscope that allows us to swing side to side, as well as doing the normal deflection up and down. So you can get different permutations of this ureteroscope that you cannot get with some other ureteroscopes. Now here's an example I'm going to show you of an impacted ureteral stone. This was done in the operating room with gravity irrigation. So often with these impacted stones, you can see this is a spiky stone. We try to push the stone and disimpact it. In this case, this stone was too stuck. We couldn't. We put the patient in reverse Trendelenburg position so the pieces don't migrate up to the kidney. And we laser the center of the stone with the TFL laser. Now, the TFL laser has gotten a bad knock, sometimes saying it causes more ureteral trauma, but I think that's more related to settings and to technique. Staying in the center of the stone under direct vision here with this small caliber ureteroscope, you can see the vision is excellent, and we can fragment the stone with pinpoint accuracy. We're able to take each of the little pieces that have broken off the main stone and pinpoint the center of the stone and hit it with 1 joule 2 hertz, which is my typical setting for fragmenting stones. And I'll keep going and getting the pieces smaller and smaller and smaller and smaller in the reverse Trendelenburg position, because the vast majority of these fragments will wash out of the ureter. The nice thing about having a 6.3 French ureteroscope is there's a lot of flow around the ureteroscope, and you can see that, all the fluid that's coming back around me and going down to the bladder. So even when we're using gravity irrigation, we're getting a continuous influx of fluid, into the collecting system. Now here we are basketing a piece of stone. You can see that there's excellent flow even with the basket in, because the working channel is 3.6 French. And really, the size of fragment you can remove is the same with this scope as any other scope, because that depends more on the caliber of the ureter. So we grab the stone, we come all the way out, and we put the stone in a basket, and then we go right back in through the urethra. And you can see, even though this is a male patient, it's really not that difficult to negotiate the urethra with a small caliber ureteroscope. The vision of the ureteroscope is almost like a regular cystoscope when you're going through these areas. And you can see there's another fragment there. So pieces are already coming out without us having to do anything because of the reverse Trendelenburg position. Now we're going to go back up the ureter. You can see that it's not that difficult to go back up. And there's some remaining fragments here. And this one is a little bit too big to come out by gravity alone. So we'll grab it, we'll pull it out, and it'll actually drag some of the other pieces along with it, like that. So we'll put that into the bladder, and then we repeat the process until the entire ureter we are sure is stone-free. That is a very spiky stone, typically dihydrate, so they cling a lot more. So it is very important to get every piece out, because you don't want to leave one of those clingy pieces around. And at the end, we always do a final ureteroscopy and pyeloscopy to make sure we haven't left any fragments inside the patient. So this is just a typical example of a totally tubeless ureteroscopy facilitated by a small caliber ureteroscope, in which case we don't use a guide wire and don't use any fluoroscopy and don't have to leave a stent in the patient. This is our final exit here out of the patient. So hopefully with these two examples you've seen now in the office as well as in the OR, you get an idea about the usefulness, utility of this scope. So in summary, a stentless small caliber ureteroscope is feasible in the office or in the OR. The outcomes are similar to the same procedures performed with larger caliber scopes. There's minimal complications. They save time because you only need one scope for the entire procedure. There's minimal trauma to the tissues and minimal patient discomfort in the office as well. It decreases healthcare expenditures. And I think in the future, the smaller caliber ureteroscopes will replace the larger caliber ureteroscopes, because there's really no downside to them that I've found so far in the cases I've done. Thank you. And I'd like to now turn it over to Dr. Casey Dauw for the question and answer session. Thank you.
Thank you, Mantu. As usual, an incredibly innovative and progressive talk. Thank you for participating tonight. So I'm joined now by Dr. Gupta, Dr. Khurshid Ghani, and Dr. Wilson Swee for this next period of panel discussion. And so maybe where I want to start just from a high level view, Mantu, is reflecting on the first two talks that we got. What do you do, or how have you approached the idea that, you know, some of your colleagues may be uncomfortable with stent emission, and what were your reflections on the talk that you got there, specifically as it relates to working with your peers?
Yeah, I totally get it. And I think Dr. DiBianco's comments that he didn't want to burden his colleagues with emergency room visits and calls to the office in the middle of the night and the weekends. He's trying to save them from any, undue work that wasn't necessary if he had stented someone. So I think that's the fear. I think that's probably the number one fear I see in my colleagues at my own institution doing it. And The only thing I could say is you just have to jump right in and start slow, start with the easy patients. I think the pre-stented patients, the protocol you have in Michigan, I think is wonderful the way you started it. And Dr. Sweet talked about how he transitioned from stenting everyone to decreasing the number of stents following that protocol. So I think that's key to have a formal plan in your mind of how you're going to progress to doing stentless ureteroscopy.
So kind of a segue from that, maybe Khurshid or Wilson could chime in. We did get some questions from the chat. One of the questions came from Jay Lonsway, one of our excellent partners here in the state, is how atraumatic is atraumatic? And I think it's a really interesting question, right? Because my definition of what that might be might differ from Khurshid, might differ from Mantu, et cetera. So Khurshid or Wilson, what can you take that one?
Yeah, I'll start here. I have to say, it's really rare for me to even dilate the ureter. So, and I have an 8-10 dilator. It's rare. And I am absolutely convinced, and I credit Dr. Clayman from UCI Irvine for this. Like, he's saying that he puts alpha blocker and he can get access sheets up easily. Opened my eyes, and there's been multiple RCTs on this. So every patient in my ureteroscopy protocol, they are on an alpha blocker. And since I've done that, I can get a ureteroscope. I think I'm not using a large caliber ureteroscope like a 9.4 French, but definitely on the 8 French size and sometimes under. So it's really rare. If I do dilate, then I have to admit that most of the time that is just a tight ureter globally, and I'm placing a stent. So that's my experience. And I think because I've been moved into the alpha blocker pathway for the last few years.
Yeah, I think enrolling patients onto SOL has really opened my eyes in terms of what you can get away with in terms of dilation. And as a part of the inclusion criteria, I know we allow up to 8-10. And so the first time I did it, I was really nervous. I said, hey, I'm going to do this. I'm going to get the scope up, treat the stone, and leave this patient or randomize them at the end of it for stent omission, yes or no. But it's really by virtue of participating in the trial that I felt, okay, this is part of a trial. We actually don't know the answer here. And so it's okay to do this. And so that helped me at least get over the mental hurdle of that.
So Mantu, I see, I share your enthusiasm for the 6.3 French scope. How have you changed your practice in light of some of these more affordable, disposable ureteroscopes?
They may be affordable, but our hospital still hates when we use them. They want me to use a reusable scope every time. And then we have to fill out a form every time we use a disposable scope. No matter how much I try to convince them that it's financially advantageous to use a disposable scope, they just don't buy it. They looked at my numbers and they say, well, you know what? When you use a reusable scope, you're only costing us $300 a case. And I said, well, that's because I have a good ureteroscope, I use a Flex X2. It's very durable. And I may get more cases out of it than the other person. But still, you have to factor in other costs that they're probably not doing, sterilization and everything. Going back to the dilation point, with the 6.3, I've never had to dilate anyone using that. So my protocol generally is I will use a reusable scope. It's a 7.5 French scope. If it does not go up, I'll dilate to 8 and then to 10, because 8's not enough to get the 7.5 up. You need to dilate to at least 10. If the 10 goes easily, and I don't have a sense for that. I know Ralph Clayman says 8 newtons is a force, but it's cumbersome to use a force gauge or some of the things he's described. So I don't do that. But if a 10 goes easily, that's a patient, even though I dilate to 10, I'm not going to stent them. I'll put the 7.5 up. And if I don't have to go above 10 because I'm using a 7.5, so there's no point. So I know you technically can go up to 12 kc, but I have never had to do that because I'm using a 7.5. And if the 7.5 won't go up, then I'm using the 6.3 French scope, because that'll go up the ureter almost always. So that's our general protocol. That's how I limit the use of the 6.3 and keep the OR happy.
Okay. Can I just add on that thread, Mantu, which is I've been using more and more of the slimline, the 6.3, like Casey has, like Wilson in our group. And I think the whole flow of the operating room is much faster. So I think that's something that we should all look at, is like, how many patients can we get through? How quicker is, I've heard from the nursing staff already that what they have to open up in the sets is quicker. the turnover might be slightly quicker. So I think there may be an argument with the health systems, Mantu, if you can study this, to say, hey, I can get more cases in. You only need to get 1 or 2 more patients in extra, and I think that definitely offsets.
You're probably not using X-ray, which also helps.
Yeah,
because X-ray take up time to use.
And personnel staff as well. Yeah.
Wilson, have you shared similar experiences with either the 6.3 French or 7.5 French disposable ureteroscopes?
Yeah, I mean, it's interesting. When we first started using them here, a few of the residents said, "Oh my gosh, this is like so light. Do we have to go back to using this other scope?" And I say, "Yeah, we should be, environmentally conscious and do it." But I fell into into just getting used to using more of the disposables. And part of my training, we used a lot of disposables too. And so it's hard to go back once you start using it ergonomically. It makes sense. And like Mantu mentioned, facilitates floorless ureteroscopy. And so there's a lot of benefits to it that may not be so easily capturable on a pen and paper.
Yeah, and I completely echo, Kirsty, we had that side conversation even today. In a scenario where turnover is often the limiting factor for us, not having to make sure that a tray that has your cystoscope, because it's not needed if you're using the 6.3 or 7.5, is present. Really, it's really minimized what we need to open for each of these cases. Have everything available for safety, but I think there's no doubt that could have a benefit on turnover